morning, everyone. It's my pleasure to be here today with you and yesterday as well. I enjoyed all the presentations yesterday. I would also like to thank Dr. Munir Abu Hilali for this opportunity and inviting me to present about the role of health economics and health policy. I'm going to introduce myself first. My name is Dr. Israa Rawashdeh. I'm an assistant professor and also the chairman of the Department of Public Health at Malta University. So, as you all know, and from this previous day and today, there is a relationship, there is a dual relationship actually between economics and health in general. As you all know, there is a notion that is always said when we talk about health and economics. It's like wealthier countries are healthier countries. There is a lot of critique to this notion, but it's still valid. We have also a relationship between economics and health policy as well. Economics is an integral part and also something that when we make health policy, we should take it into consideration. In economics, in order to make a health policy that is dependent on economics, we also need evidence. So I'm going to use the Walls and Gilson framework or model for making any health policy. The model also, in summary, is just what are the things that we should take into consideration when making a health policy or when analyzing an existing health policy. As you all can see, we have the content, we have the context, we have the process, and we have the actors that will be involved in the making the health policy. Economics always lies in the context part and also in the content. So we can't make any health policy without giving attention to the social insurance, the financing health services, to the structural factors, so the economic situation of the country, which classification the country belongs to. If you want to understand health policy, we should also understand the public policy first. We have two approaches. Either we understand it according to which side does it lie in. Like in public policy, we have something that's called high politics, which includes defense, security, and economy. And then we have the low politics that includes welfare, education, health. There is a trade between all of these. And from all you have noticed yesterday that we are talking about health economics. So if we are combining both the economy, which is high politics, and then the health, which is considered a low politics, I'm just going to ask you this question. Are we moving health, if you combine, if we're studying it from an economics point of view, into making it a high politics? Are we paying attention more to health when we are talking about resources and allocating these resources? The other approach is the health studies approach. So if you are making a health policy, we have to see whether this intervention X, for example, works, if the intervention is cost effective, and that's you have all covered yesterday. So this is okay, we have talked it. So public health or health policy is multidisciplinary. There are a lot of things, and economics is one of them that we should consider. There's also a lot of perspective and a lot of insights, and the role of health economics, in my opinion, in making the health policy is that bringing a new insight and understanding to any health policy. Economics is a way of thinking, as you have seen. How economists think? Usually, a health economics economist usually focus on four main questions. First, what types of goods, and I mean by goods, any goods or pharmaceuticals are included as well, and also services, what type of these goods are being provided, and how much should we provide of each one? It's all about rationing. What resources are required to provide these goods, and who has access to these services? Equity is very important, as Elena highlighted in the previous presentation. Also, can we get the same goods using fewer resources? It's like about cost effectiveness and efficiency. So what is a good decision? What is a good decision in health economics? Also, a good decision, in my opinion, is based on all of these. If you consider all of these in making a health policy, the scarcity, the choice and opportunity cost, the margin, the efficiency and equity, I think it will lead us to make a good decision in making the policy. As you all know, like wants are unlimited, but sources are. That's why we have said the health economics is about the scarcity knowledge. Also, despite increase in the spending, as you have seen also yesterday, we spent like 9% of our GDP in Jordan, but we haven't decreased the demand. So the demand is increasing, the sources are not. Now about rationing, do we really need to ration? Yes, because more money doesn't solve any problem. New technologies have evolved, but the new technologies, they created opportunities for us, but at the same time, they had not covered all the demands, and they are making the demands increasing, the new technologies. How about equity? Equity is one of the blocks that are important. And as you have seen yesterday, efficiency and equity are always conflicting principles. That leads me to my recent work. First of all, in any health policy, the core to make any health policy is research. And in Jordan, we are lacking this research. The first thing about research that we have made recently a study that talked about disparities in cesarean section among women in Jordan. We depended on the data from the latest Jordan Population and Family Health Survey, 2017-2018. There's the link for this study. Cesarean section in Jordan is a new technology, and we have already said that technologies in health economics increase the demand. Cesarean section is an example of these technologies. It makes safe childbirth. It helps mother to childbirth. The WHO, however, sets a rate that cesarean section should not exceed 10% in any population, but many countries have exceeded this rate, including Jordan. Jordan has one of the highest C-sections in the region. For example, during the past years, from the 90s, let's say, until the 2017, we have a cesarean section that is nearly 20.8% prevalence of cesarean section among the deliveries. It's a very high rate. It's like more than even doubled the rate set by the WHO. We have made some literature review that we found that cesarean section is related to some social demographic factors and characteristic and associated with increasing or decreasing these cesarean section use. And we also have found that there are disparities, actually. There are disparities between women. These disparities depend mostly on the socio-economic characteristics for these women. There is limited evidence from Jordan. So we asked ourselves, what are the main factors that are associated with the C-section in Jordan? And are there any disparities in the context of the social determinants related to C-section deliveries? As I told you, we have used the data from the DHS, the last one. Our study included 6,672 women in this study. The framework included social demographic variables to determine these disparities, the women decision-making ability, whether they can decide about their health, make a decision, and also a health system variables, including health insurance and also the place of delivery. This is just to explain what exactly the independent variables that we have studied. Our findings. We first found that nearly 27% of women were delivered by C-section. This is like third of women. This is a very high percentage. Our study also found that the most socioeconomic factors that were related to the C-section were the mother's age, were also the region by governorate. We found that the most C-section happened in Madaba and the least ones happens in Aqaba. Okay, there is a variance between these governorates. We also found that there was no relationship between wealth, for example, and for example, nationality, if we compare Jordanian to Syrians, and also the person responsible for making the decision. But at the same time, we found a significant difference in relation to the place of delivery. Private sector has more delivery, significantly more than public. So in private sector, more cesarean sections happens actually. So by logistic regression, we also found that the odds ratio of cesarean section for women age 40 and plus is 3.3 compared to women under age of 20. The odds of having cesarean section is 40% higher for women who delivered in a private hospital. This is a very alarming, actually, number that tells us a little bit about the health policies and the practice of cesarean section and the use of technology in the private sector. We need some, it highlights the need for rationing this, using this technology. The odds of cesarean section also as 60% lower for women living in Aqaba compared to women living in Amman, and 60% higher for women living in Madaba compared to women in Amman. I would like to highlight something here. In the previous three DHS data reports in the 2012 and 2007 and also 2018, Madaba has always been the first governorate to have more C-section. Unfortunately, we don't have data about how differences in the practice in cesarean section in the public sector or in the private between governorate. That's why we couldn't actually explain this difference. So our findings highlight the increased practice of cesarean section and the importance of developing a national and subnational policies that include clear guidelines for the practitioners to decide actually when they are going to use C-section. We know that there are many factors related to the health system itself. Some doctors prefer to move the women to cesarean section because they are afraid of like lawsuits or high, and also take the shortest, safest way. So we need to ration this use of performing C-section. Also, I think related to our gathering today, it highlights the need for further research on the economic impact of C-section. I didn't find in the literature review any studies about the cost of cesarean section, the impact, or the cost effectiveness of using cesarean section in Jordan. So this is an opportunity for research in the future. And now I will hand on the mic for Dr. Anas to talk about.